Before I start, I want to thank my dear friend Vasilis for extending this kind invitation to me to be here today and indeed share my own perspective on the role of high-density lipoprotein in cardiovascular disease and beyond, because from what I'm going to say, there is strong evidence that high-density lipoprotein plays a very important role in diseases like obesity and diabetes. But unfortunately, it is the example of the element that we do not understand, and if we don't understand, we tend to ignore it. But I think that at the end of the presentation, all of us will agree that high-density lipoprotein is something that we should definitely consider for the benefit of the patient. It is true that it is a very mysterious lipoprotein. It's a very mysterious lipoprotein. We know it for many years, and it has been a long target for coronary heart disease prevention and treatment. However, all of us who do research in this field, we feel lost. We feel lost. It seems like we're working somewhere in the Bermuda Triangle, because anytime we think that we made an advance, there is always a problem. And this problem is how we translate this advance in scientific findings in benefit for a patient. There is strong evidence that high-density lipoprotein, and in particular, dysfunctional HDL, plays a significant role in the development of numerous conditions such as obesity, stroke, non-alcoholic fatty liver disease, diabetes, bone metabolic disorders, in addition to atherosclerosis, which is the long time established disease that has been associated with coronary heart disease. And this is because high-density lipoprotein is not just a cholesterol. We like to refer to cholesterol because it's an easy biochemical marker. However, it is a lipoprotein particle, which is composed of proteins, lipids, enzymes, and they all come together into a particle like the one I show you here. And not only that, but many different proteins, as I said, and with different functions, they tend to be associated with this particle. And we also know that it's not just a single particle, it's a mixture of different particles and of different geometry. So we have spherical particles, we have small particles, big particles, discoidal particles, and they all are classified as high-density lipoprotein. We know that the main component, the main protein component, is apolipoprotein A1, which is primarily responsible for the HDL that we have in circulation. However, we also know that other apolipoproteins like ApoE and ApoC3, they are also capable of forming HDL. And we know that, for example, ApoC3 is a target for new hypotriglyceridemic medicines. And so we start understanding a little bit better the relationship between high-density lipoprotein and triglyceride levels, etc. But it appears that it's a very complex system, and it has a very complex metabolism. Moreover, adding to this complexity is that by altering the protein composition of HDL, you alter the lipid composition of it. So for example, if you have ApoA1 containing HDL particle, then you tend to have a more charged polar surface on charged lipids that are present on the surface of this particle, and this facilitates interaction with numerous plasma enzymes. However, if you have a particle that doesn't have ApoE1 but has ApoE, then immediately you lose this polar surface and you have substitution of these lipids with non-polar lipids. And this is work we have done in collaboration with my dear friend Anatole Contouche from Sorbonne University in Paris. We also know, we say that HDL is antioxidant, but we now know that not every HDL particle is as antioxidant as we would like to believe. So some apolipoproteins contribute to the formation of antioxidant HDL. Some, they do not contribute, or they are even pro-oxidant. And the same thing is happening with inflammation. So or with cholesterol reflux and inflammation. So, for example, we know that ApoA1 promotes reverse cholesterol transport, and this is a main property that we consider as protective. Nevertheless, we know now that it's ApoE1 that facilitates this process. However, if we substitute ApoE1 with any other apolipoprotein, then we no longer have that reverse cholesterol transport effect. And the same thing is happening with HDL containing, when we look at it in inflammation. We think that HDL is anti-inflammatory, but it doesn't happen all the time. So, for example, ApoE1 containing HDL, even though it facilitates reverse cholesterol transport, if you have too much of it, then it's pro-inflammatory. So the idea is that you need to have a little bit of everything so that you eventually you have the benefit. And that's why it's very hard to really understand and assess and capitalize on all the scientific advancement for the benefit of the patient. So as it turns out, apolipoprotein component of HDL, it's the apolipoprotein scaffold, it's the backbone, the protein backbone defines to a great extent what lipids will be loaded, and then both of them will define whether, for example, we have functional HDL or dysfunctional HDL. So as I said, we need all particles, we need a certain composition. So this is what we're trying to understand. What is the golden ratio so that we have all these particles that will contribute to atheroprotection. However, as I said, it's not only atheroprotection. HDL plays a very important role in other conditions, and we know for a long time that people with metabolic disorders and metabolic syndrome in particular, they could have obesity, they have insulin resistance, and at the same time, they have a very peculiar type of dyslipidemia, which is composed of low HDL cholesterol and high triglyceride levels. So the idea here was to try and understand how HDL may be related to obesity at first, and then with pancreatic beta islet function in the second part of this talk. So I would like to remind everybody that we have that adipose organ is divided into white adipose tissue, which is a storing tissue. It's a tissue that is designed to store lipids, and this is the kind of tissue that creates the problem when we become obese, and also with brown adipose tissue, which is designed to consume lipids. So it's not the storing tissue, it's not a tissue that's going to accumulate lipids, it's rather a tissue that's going to use lipids, it's going to burn lipids towards production of energy in the form of ATP or in the form of heat. And we know that oftentimes we can even transdifferentiate, as we say, white adipose tissue into brown adipose tissue. So we can make white adipose tissue, brown adipose tissue under certain conditions, one of which is exposure to low temperatures. And that's how it was first identified, this transdifferentiation process, when a Japanese principal investigator locked in the cold room his assistant for a couple of hours, and then he ran a PET scan and figured that indeed white adipose tissue started having brown adipose tissue characteristics. And everything happens in the mitochondria. In the mitochondria of the cells, because that's where oxidative phosphorylation takes place, and that's where we have ATP production. At the same time, we have thermogenesis through uncoupling protein 1, which uncouples oxidative phosphorylation from the production of ATP. So in a set of experiments that we did was to try and understand how qualitative changes in HDL may impact obesity and diabetes. And in this case, of course, this is something we cannot do in a human model. So we went to the animals and we used mice that do not have ApoE1, so they don't have classical HDL, or mice that they have ApoE1, so they can make some HDL. However, they don't have the maturating enzyme for HDL, lecithin cholesterol transferase, and as a result, they form only discoidal HDL particles. They cannot proceed to form mature spherical HDL particles. And we looked at what happens to HDL in obesity. Indeed, when we fed these animals Western type diet, immediately we saw that they would gain much more weight compared to the mice that had fully functional HDL. So if you have this functional HDL, if you don't have HDL, or if you have dysfunctional HDL, then immediately you start seeing an increase in body weight, and significant increase in body weight, which is associated with the lack of UCP1 expression of the thermogenic protein in white adipose tissue. So in other words, you remove HDL, you remove functional HDL, and then you immediately start losing UCP1 in mitochondria. So your mitochondria can no longer burn, and that's why you have accumulation of lipids. These lipids cannot be burned, and you have accumulation of lipids. And this was much more profound in white adipose tissue compared to brown adipose tissue. When we looked on HDL and diabetes, we did a similar type of analysis, but now with a classical test that we use to assess the glucose tolerance in different systems, including humans and mice. And here we saw that if you don't have any HDL, then from the beginning, glucose tolerance is disturbed. So these are classical glucose tolerance curves. You see that if you don't have the ApoE1, which is here, even at basal level, you have disturbed glucose tolerance test, and immediately, once you feed these mice a Western type diet and you make them obese, then you have a further disturbance of this glucose tolerance. So we wanted to know how this happens. So we isolated the soleus muscle, the skeletal muscle of this mouse, and we did what we call insulin stimulated glucose uptake in this skeletal muscle. So we saw that, just to make the very long story short, that if you don't have HDL, then the skeletal muscle can no longer respond to insulin, something which is very, very impressive. So if you have low or dysfunctional HDL, this establishes a condition which is associated to insulin resistance. But at the same time, pancreatic beta islets can no longer function as they should. So, for example, if you don't have the ApoE1, then if you stimulate pancreatic beta islets with glucose, they can no longer secrete insulin. They make insulin, they make a lot of insulin, and this is the insulin that they make inside the cell. However, they cannot secrete this insulin upon glucose stimulation. So it appears that plasma membrane plays a very important role. Plasma membrane plays a very important role, and we know now that if you don't have ApoE1, if you don't have classical HDL, you start having a very rigid membrane because cholesterol efflux is not efficient. You have a lot of cholesterol that stays in a plasma membrane. This is like having rocks of cholesterol on plasma membrane. This is an obstacle in the proper function of proteins. And as I always tell mainly to students, it's one thing to try and clap your hands in open air. The another thing, if you try to clap your hands in a swimming by diabetes, exactly this correlation. In the past, there have been many efforts to try and understand how we could have a successful marriage between high-density lipoprotein and pharmacology. However, this led to bad divorces. It was not successful.
And we know that there have been different medicines that were proposed. The most important of the niacin is still in the market, and I'm going to discuss it a little bit. The most important experimental medicines were CTP inhibitors, which they created a source of debate. The source of debate because some of them were not successful, but some of them were successful. So the idea is why some of them succeeded and the other did not succeed in providing better. The higher the cholesterol. We know that this is no longer true. We know that there's a U-shaped relationship as similar to what we saw before with Professor Margaret's presentation. Same thing happens with high-density lipoprotein. U-shaped relationship. So if you have too little HDL, or if you have too much HDL, then you can have high risk of developing, for example, coronary disease. So the optimal range should be between 40 and 70 overall. Could be, let's say, 40 and 65 or 45, but overall it should be somewhere between 40 and 70 milligrams per deciliter. And so the problem with all trials that tested the HDL hypothesis, the HDL raising hypothesis, is that they were based on the old mentality that there is a straight correlationship, and the higher the HDL cholesterol levels, the better it is for the patient. And as a result, they were using a high dose. For example, the CTP trials, they were using a high dose of medicine that would shuttle the patient from very low HDL cholesterol levels to very high HDL cholesterol levels, where still the patient has significantly increased risk. So now there are trials that are designed with lower doses, trying to shuttle the patient somewhere in the middle, where he or she are expected to have a better response and a lower probability of developing coronary heart disease. So especially for the CTP medicines, now we have the revival of the field with the obicetrapib, which is the new CTP inhibitor that is being used at very much lower concentrations. Instead of using 40 or 60 milligrams per day, the obicetrapib trials use usually 5 to 10 milligrams of medicine, because the idea is to shuttle the patient from very low levels of HDL to the intermediate levels of 40 to 70, and this way make bring the patient to where he's supposed to have the lower risk for coronary heart disease. And the ROSE trial was very successful. The profile was very impressive. There was a significant improvement in all parameters, in lipid parameters. And so now we are expecting for the Broadway trial, which most likely will be completed in September 24, most likely next year, this time next year. And so we will also know how the benefit in lipid profile may correlate with benefit to cardiovascular risk, as well as other conditions associated with cardiovascular disease. I told you about niacin. Niacin is a medicine that has been already in the market. It is available. Niacin is licensed. It is still in the market. Maybe you cannot find it very easy in countries like Greece, for example. But the question is it ineffective in improving coronary heart disease? Well, if we look at the AIM-HIGH and the HPS2 THRIVE trials that declare niacin ineffective, we will see that they have tremendous limitations. And I think that this was not fair. Justice was not made to niacin through these clinical trials. And the reason is that we know that it raises HDL cholesterol by approximately 30%. This is what we pretty much want to bring a low patient to the optimal level. It reduces LDL cholesterol by 14%, reduces triglycerides and ApoB48 by 30%, and at the same time decreases Lp(a) by 32%. If you think about it, statins increase Lp(a). So if the hypothesis of Lp(a) is correct, then niacin not only increases HDL cholesterol and reduces LDL, but at the same time reduces Lp(a), another cardiovascular risk factor. So I think that the trial should reopen. I think that we should not just discount the niacin right away, and we should start rethinking about it as a useful medicine, cheap, useful medicine that can be used to treat at least a certain type of patients suffering from coronary heart disease. So if we have a man, 45 years old, of HDL cholesterol 30 milligrams per deciliter, or a woman, 58 years old, of HDL cholesterol 110 milligrams per deciliter, should we be happy? Well, certainly there is not a single trial saying that if HDL cholesterol is low, then the patient is safe. If HDL cholesterol is low, it's always a risk factor. The reason that we don't include it in guidelines is because we don't understand it very well. However, there is not a single trial, the Framingham Heart Study, the Scandinavian Heart Study, the Copenhagen Heart Study. If you have very low levels of HDL cholesterol below 40, then you are at a higher risk of developing coronary heart disease. But now it's also the very high levels, which also quite problematic. In the past, we used to say, oh, don't worry, you have HDL cholesterol 120, that's great. But no, the truth is not great, because we know that the relationship now is U-shaped. So you have as much of a problem, you have 110, as if you have 20. So we should care, and we should intervene to the best that we can. If we have very low HDL cholesterol levels, as I said, well, niacin is not available in Greece, but as I said, niacin can be a very useful tool to raise HDL cholesterol. But just because there is an inverse correlation between HDL cholesterol and triglyceride levels, it's very important also to consider the use of omega-3, for instance, EPA, IP, Vascepa, which will be entering the Greek market soon, or even fibrates like gemfibrozil. And of course, we should increase physical activity, keep away from saturated fats, try increase alcohol consumption, because moderate alcohol consumption, maybe a few glasses per week, can increase HDL cholesterol. And of course, stopping smoking. Smoking cessation is very important to raise HDL cholesterol levels, low HDL cholesterol levels. On the other hand, though, if we have elevated HDL cholesterol levels, now this is much more difficult, because there's not a single treatment at the present time for abnormally elevated HDL cholesterol levels. And usually elevated HDL cholesterol levels are due to mutations. There are mutations, and the hyper alpha lipoproteinemia syndrome is associated with elevated HDL cholesterol levels. So it's very important to consider that the patient has an additional risk factor. So all other lipid factors should be more aggressively treated. So we should increase the aggressiveness in reducing LDL cholesterol, triglycerides, because the elevated HDL cholesterol levels, they should not be perceived as a positive, but rather they should be perceived as a additional risk factors that the patient has. Of course, we have also lifestyle changes, change to low-fat diet. If a patient has hypothyroidism, it's very important that we treat it too. Treat inflammation associated with diseases, primarily primary biliary cirrhosis, and also change medication, because sometimes check medication, because sometimes medication may be responsible for exorbitant increases in HDL cholesterol levels. So I think that HDL cholesterol is a very important lipoprotein. It is a mistake that at the present time we don't include it into guidelines, and the reason is that we don't understand it very well. However, I think that as the quest goes on, we will understand much more about this lipoprotein. In particular, we will give the opportunity to the sleeping beauty of the HDL, of the lipoprotein world, that is HDL, to find her prints for the benefit of patient. And before I close, I will definitely like to thank all my friends and colleagues all these years. I've been researching this field for over 25 years. And I have many colleagues who participated in numerous studies that I presented here. And I want to thank them all. And of course, I want to thank again the organizers. Vasily, thank you so much for giving me the opportunity to be here. And also, I would like to thank you for listening to this presentation.